Welcome to this explainer. Okay, so today we're diving straight into a fascinating medical mystery. We're going to explore a really dangerous diagnostic trap, one that every graduating medical student and junior physician absolutely needs to master. We're talking about the critical and honestly often misunderstood difference between morning stiffness and actual morning paralysis. Because as you'll see, confusing the two can lead you down a very, very risky path. Let's get right into it.
To get our inner clinical detectives fired up, let's look at the case we'll be solving today. Imagine a 45-year-old woman. She's got a 3-year history of rheumatoid arthritis, RA for short, and she regularly takes 8 milligrams of Metaprid. Now lately, she's been experiencing this severe, really terrifying morning weakness in her lower back and thighs. So naturally, what'd she think? She assumes her RA is flaring up, and she self-adjusts, right? She bumps up her own hormone dose. But instead of getting better, she suddenly finds herself completely unable to get out of bed, just suffering from this deep, aching pain. So why did her self-treatment fail so spectacularly? Keep her in the back of your mind as we unravel this.
Now, to crack this case, we have to look at the core juxtaposition of what's actually happening inside the body. We've got to completely separate two drastically different pathologies. On one hand, you have autoimmune inflammation. Think of this as the classic cytokine storm wreaking absolute havoc inside an inflamed synovial membrane of a joint. But on the exact opposite side, we have an electrolyte imbalance. This is literally an electrical failure, an ion channel dysfunction happening right at the cell membrane level. Basically, we're looking at a structural issue versus an electrical issue. And trust me, treating one like the other, it's a total recipe for disaster.
This comparison right here, this is where the diagnostic magic happens. You know, students often mistakenly link any complaint of morning stiffness straight to joint inflammation. But look at the actual nature of the symptom. In RA, the patient has stiffness, meaning their muscle force is completely preserved. They can move, it's just really painful. But in true hypokalemic myopathy, we see paralysis or paresis. Muscle tone and force are entirely lost. The muscle simply will not contract. And the localization is totally different too. RA typically hits those small, symmetrical joints, think hands, wrists. Hypokalemia, though, knocks out the massive, heavy-lifting muscle groups like the lower back, the buttocks, the thighs, and the shoulders. And that brings us to what is essentially the ultimate clinical paradox between these two conditions. In rheumatoid arthritis, getting out of bed and forcing yourself to move actually helps. Movement improves the microcirculation, it activates lymph flow, and it helps absorb that inflammatory joint exudate. They literally work the stiffness out. But in hypokalemia, it is the exact opposite. Attempting to move or, put any kind of load on those resting, potassium-starved muscles doesn't help at all. It triggers excruciating spasms and cramps. Resting is painless, but moving is just agonizing.
So the really crucial point here is understanding what actually triggers these morning episodes, because the provocateurs are wildly different. We know RA is typically triggered by things like chronic stress, cold, damp weather, or maybe a recent infection. But hypokalemic paralysis, it has some truly bizarre and fascinating triggers. Ask yourself, did the patient eat a huge meal of bread and sweets late at night? Did they take a really hot bath and sweat heavily? Or maybe they just rested after some intense physical fatigue? Listen, a late-night carbohydrate binge followed by sudden morning paralysis is a massive, flashing red flag for an electrolyte issue. Definitely not an autoimmune flare-up.
Now at this point you might be thinking, hey, let's just run an immunology panel and figure this out. And yeah, it's true. Anti-CCP immunology has a fantastic 95% specificity for diagnosing rheumatoid arthritis. It's an absolutely incredible tool for establishing the baseline disease. But here is the trap. That 95% specific test, it is not going to help us diagnose the cause of a sudden acute morning muscle failure. The immunology tells us she has RA, sure, but it doesn't tell us why she can't move her legs today. For that, we've got to look somewhere else entirely.
So where exactly do we look? Right at the heart's electrical system. To rapidly confirm the presence of a dangerous electrolyte drop, specifically a lack of potassium, you have got to look for these specific ECG signs. You'll see a lowered T-wave amplitude, a clear depression in the ST segment, and the sudden pathological appearance of a U-wave. An ECG is fast, it's non-invasive, and it can instantly alert you that the patient's electrical system is failing due to low potassium, way before the blood lab results even come back.
Which brings us to the exact pathophysiology of why those weird triggers we mentioned earlier cause such a catastrophic morning. We call this the nighttime potassium trap. Okay, step 1. The patient eats evening carbohydrates, which heavily stimulates insulin secretion. Step 2. That insulin, combined with nighttime hormones like adrenaline and cortisol, hyperactivates the sodium-potassium ATPase pump. Step 3.
Potassium is forcefully driven out of the blood and shoved straight into the muscle cells. And finally, step 4, this sudden extracellular hypokalemia completely strips the cell membrane of its electrical excitability. The result? A total muscle blockade by morning. The muscles are, quite literally, unplugged.
There's a crucial, absolutely vital detail here for any clinician trying to differentiate these symptoms. When that patient tries to sit up in bed and feels a sharp aching pain in their back, guys, that is not joint stiffness. Because the myocytes, the muscle cells, are completely depleted of the potassium they desperately need to function. Forcing them to work causes localized ischemia. You're looking at a tetanic cramp from a starved muscle cell, practically screaming for electrolytes.
So, you're probably wondering, how did our RA patient get so dangerously low on potassium in the first place? Well, welcome to iatrogenic hypokalemia. Iatrogenic meaning, of course, caused by medical treatment. Patients with RA, lupus, or systemic vasculitis are very often on long-term glucocorticoids like prednisolone or metapred. Now, these life-saving drugs have a pretty dark side. They brutally block potassium reabsorption in the kidney's proximal tubules. They literally force the kidneys to flush the body's potassium right down the drain via the urine. So treating the RA is exactly what caused the electrolyte imbalance. All right, armed with this pathophysiology, let's circle back to our 45-year-old medical mystery. Why did her self-treatment fail so drastically? Remember, she woke up weak, thought her RA was acting up, and totally doubled down on her methoprid. Well, her blood labs showed she was still rheumatoid factor positive, and her ESR, a common marker of inflammation, was mildly elevated at 18 millimeters per hour, which honestly is pretty standard for her baseline. Literally nothing in her lab screamed massive immune flare-up. So, let's rapidly break down the solution to her case. The true cause of her morning paralysis? It wasn't her arthritis at all. It was iatrogenic hypokalemia caused directly by her methopred prescription. And the worsening factor? When she tragically increased her own hormone dose, she just accelerated that renal potassium loss. She flushed even more vital electrolytes out of her system and deepened her own muscle paralysis. To fix this, our emergency actions are crystal clear. First, immediately check her blood potassium and run that ECG to look for U waves. Second, we absolutely must reduce the methopred dose and urgently replenish her system with potassium chloride. And you know, there is this brilliant, incredibly elegant way to prove this right in the clinic. It's known as the ex juvantibus diagnostic test, which basically means reasoning from the success of the treatment. Check this out. If you have a hormone-treated RA patient complaining of general muscle paralysis in the morning, just give them a potassium preparation like KCl, Panningen, or aspartame right before bed. If they wake up the next morning and that paralysis is completely gone, boom. You have definitively proven that the weakness was a hormonal drug complication and absolutely, unequivocally, not a rheumatoid flare. It's such a simple yet totally life-changing clinical trial. Which really leaves us with this final, incredibly provocative question to chew on. If your treatment causes the paralysis, are you treating the disease or are you just treating the drug? It's a really powerful reminder of the iatrogenic trap. Every single prescription has a physiological echo, and as we've seen today with RA and methoped, sometimes the symptoms of the cure end up being far more dangerous than the underlying disease itself. Stay curious out there, keep looking past the obvious, and thanks for joining me on this explainer. See you next time.